Terrific. Thank you so much. Good morning, everybody. Welcome to BC Women's Research Rounds. I'd just like to start by acknowledging that the Women's Health Research Institute, we're uninvited guests on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And as a provincial research institute committed to improving the health outcomes of women, including those across the 2S LGBTQIA+ spectrum, we recognize our responsibility in the collective effort towards establishing culturally safe care systems and services that address health inequities among Indigenous peoples, especially Indigenous women, girls, and Two-Spirit peoples. And we encourage all people involved in research to read both the Truth and Reconciliation Commission of Canada Calls to Action and the In Plain Sight report and reflect on the ways that we can incorporate the recommendations into our work. And as we gather in spaces together, we encourage you to reflect on your positionality on these lands and your personal commitments to reconciliation. So with that, I am very pleased to be able to introduce our round speaker for today. Professor Helen Skouteris is a Monash-Warwick Alliance Joint Professor of Health and Social Care Improvement and Implementation Science, a Fellow of the Academy of Social Sciences in Australia, and Head of the Health and Social Care Unit in the Faculty of Medicine at Monash University. As head of the Health and Social Care Unit, her multidisciplinary team drives and models a co-developed strategy that informs the research that they do, with equity at the heart of intersectionality, capacity building, collaboration, and innovation for impact, and with an unrivaled commitment to consumer and community involvement. So please join me in welcoming Professor Skouteris.
Thank you very much, Catherine. That's a really lovely acknowledgement of country. I too would like to acknowledge the traditional owners of the lands on which we work and meet today, and always pay my respects to elders past and present. I'm going to move on from the introductory slide, but thank you to everyone for attending today. So I'm going to talk today about, I will go back, embedding equity in implementation science from the outset, and I'll take you on a little bit of a journey about that. So these are my parents, Bill and Angela Skouteris, and they are pictured there. The photograph is of the three of us several years ago now. That's at the top of my mum's village in Greece. And you can see the pain in their face, and that's because they were migrants to Australia in the very early 1960s. They were invited to come to Australia. It was a time when the Australian government was actually nice to migrants and to refugees, and they needed to leave Greece because their parents couldn't afford to keep them. They were one of many siblings, each of them in their respective families, and grew up in pervasive poverty and needed to pursue a different life, and a life that potentially could lift them out of poverty. So this is the result of them coming to Australia. This is my family. So this is my husband. He also has parents who migrated to Australia from Greece, so exactly the same scenario as me. And these are our two children. We're all tertiary educated. And, I'm only telling you that I'm a professor because you know I'm a professor. But you can clearly, you would clearly know that I have succeeded in just one generation. So parents who actually were not educated. They didn't even finish primary school. But parents who were given an opportunity for work as soon as they arrived in Australia. There was work and there was continued work all of their life. They were always employed. They never experienced unemployment. They had free healthcare. They had free education for their children, tertiary education as well. not just primary and secondary. And they had extra support. They had GPs coming to their home. You know, our family doctor would come to our home because he recognised that mum and dad need that extra attention. Teachers would come to our home because they, again, recognised that mum and dad, as migrant parents who didn't speak English, needed extra attention. So in one generation, we severed intergenerational disadvantage because my parents were born into poverty. Their parents were poor, okay? And we know that if you can provide health, education, employment, it's not rocket science, is it? We will lift people out of intergenerational disadvantage. This is a very, very good example of how you can do that. Not only did the system in the 60s lift my parents out of poverty, it actually created a privileged family. You know, a family now, my family, that lives in complete privilege, right? With complete privilege. My children and myself. I really wanted to tell you that story because it will set the scene for the whole talk. I'm a developmental psychologist. You're probably not surprised, given what I just told you, that I've always been interested and have pursued this passion throughout my entire career for the best start to life for all children, irrespective of where they're born, irrespective of the colour of their skin, irrespective of the background in which their parents have been born and lived. All children deserve and must have the best start to life. So what I've done over the years is I've focused on this. You know, I've always wanted to know how we can do that. And in the beginning, a lot of what I did was focused on basic research, what matters. And then, of course, I moved into randomised control trials, like many of us do, to understand what works in terms of promoting the best start to life, in terms of promoting children's development. And now you would have heard from my position title, Health and Social Care Improvement and Implementation Science. Now I'm focused on that pointy end of what translates. And so wanting to understand how we can push beyond just what we know matters epidemiologically and what we know works in a very controlled environment to what we know actually makes a difference in the real world. And, you know, I use inverted commas because this is not the real world, okay? Where we are now and how we conduct our research and what we do is not the real world. We've got to always keep that in mind. The real world is not made up of PhD graduates and professors, okay? And so we always have to remember that as well. And we'll keep talking about that. So that's where I'm at now. And of course, with implementation, I really like this picture because it really tells it as it is. So we can do a lot of work in the what matters. I'll go back. We can do a lot of work in basic research, and we're very, very good at it. And we can do a lot of work in clinical research, randomised control trials, and we are really, really good at that as well, okay? So we end up with all this knowledge and we think we are fabulous because we've got all this knowledge. We are so great as, you know, academic scholars. But actually, we need a little miracle after that to make sure that our work is making a difference. And if our work is not making a difference, then actually we are not as great as we think we are. Right? We've got a lot more to learn, a lot more in terms of continual learning, and that's great. That's what we're here for. So we've always got to keep that in mind as well. So I'll give you an example of some of the work that I do. Healing Matters is the Healthy Eating, Active Living Matters program that was designed for young people, children and young people who are living in out-of-home care. Those are the children that have been removed from their biological parents because of sexual, physical, or emotional abuse. And they are also children and young people who are living with most disadvantage, most vulnerability, and are also 2.5 times more likely to be living with overweight or obesity. They have a lot of other medical issues. I am focusing in on the very high prevalence of overweight and obesity. And I came in as a behavioural psychologist, developmental psychologist, as I said, focusing on overweight and obesity, because I felt that it was very important that these young people are not living with overweight and obesity. It was a very top-down approach to begin with. Healing Matters was designed by me and other developmental psychologists. And as soon as we were awarded a very large grant and we moved into the sector to implement what we thought was an important intervention, we received a lot of resistance from carers. And the carers who look after these children and young people are also predominantly living with overweight and obesity. Many of them also have a lived experience themselves of out-of-home care. So basically, you know, that was me, little Miss Know-it-all, who thought that I was doing the right thing. You know, I was coming in with the goal to reduce the prevalence of overweight and obesity. And, you know, I should have just been wearing one of these T-shirts when I, you know, walked into their world. Not, you know, remember what I said, you know, I'm a professor and I'm going into a world which I have no experience of. And you saw my children, we have no experience of disadvantage, vulnerability, poverty, you know, the circumstances in which these young people find themselves, trauma. And I am walking into their world and I'm telling them, I know it all. I'm here to fix your problems. If we take a little bit of a step back and really think about, you know, me doing that, it's not good, is it? Right? So, you know, I should have just been wearing this T-shirt, you know, I'm a professor, to save time, let's just assume that I'm never wrong. Because actually that's the type of attitude, even though at the time that's not what I wanted to convey, that's actually the attitude, though, that I was conveying. And so really important that we learn from our mistakes. That's why academia and research can be very, very fulfilling if we actually continuously learn. And I learned a lot through that experience, especially what I learnt, and this was over 12 years ago, what I learnt was I'm not doing research like that again. Okay, now remember those words because I'll come back to them. So flipping the paradigm was really important to me. At the time, I realised that I've lost. There was resistance. I've got grant funding. I've lost the people that I'm aiming to work with and to support. So I needed to flip the paradigm. I needed to actually stop being the know-it-all professor and actually start listening and, you know, really understanding what it is that they needed. And so flipping the paradigm was terrific. I also needed to move away from investigator-initiated to strategic prioritised research. And by that I mean really focusing on strategically, not from an investigator's perspective, but strategically, what did the sector, what did the young people in care, what did the carers really need to support health and wellbeing? Okay, so you can see the pieces of the puzzle there. They will always remain a mess like that if we're doing solely investigator-initiated research. Okay, if we start flipping the paradigm, working with community, really listening and understanding their needs, actually involving them, not consulting them, involving them and being led by them. So we're more in service in terms of our research as opposed to leading. Those pieces of the puzzle do come together. And it's really nice to see that. It really, really works. So Healing Matters ended up being co-designed in that way. I involved young people. I involved carers. I involved other public contributors who, like policymakers, were focused on Healing Matters being part of, I guess, the fabric of out-of-home care. And so now Healing Matters is included as best practice in Victoria. It's also included in Victoria is the state in which I live in Australia, and is also included in Victoria's most recent Healthy Kids Health Futures 5-year action plan. So you can see there it's converted into policy. It's being scaled up across not only Victoria, the state in which I live, but also another state of Australia, South Australia, and parts of another state, New South Wales. It's award-winning. It's won lots of awards now, which is fantastic. The Victorian government has continued to fund me and my team, and they would like health promotion guidelines that promote Healing Matters. It's basically, it has really changed the way in which out-of-home care is offered. So that's a really fantastic thing. And you think I should be happy. Well, actually, not all children were benefiting. So again, when I said to you, I'll come back to this, even though, again, I thought, great, I'm flipping the paradigm, I'm doing all the right things, this is going to be fantastic. I actually was not following the genuine approach to equity, and I left a lot of children behind. That's not good enough. So you can write the script, and it's embarrassing to tell you, but I left behind Aboriginal and Torres Strait Islander children. They are overrepresented in out-of-home care. They were not part of the co-design process. I left behind LGBTIQA+ young people, and there are many in out-of-home care. I left behind children with disabilities. Again, there are many children with disabilities. I left behind refugee and migrant children, and that's not good enough, right? So you can see that even though Healing Matters is embedded as best practice, you can see the accolades, 3 times award-winning, health promotion guidelines, action plans. What does that tell us? That tells us that actually governments will move on. Governments will fund, and they will move on, and they will say, big tick, we're doing amazing work. It's up to us actually to say, hey, government, stop. Actually, this is not good enough. We are leaving children behind, and we should not be doing that. We should not be discriminatory. We should be inclusive of everything we do. If we don't, right, governments will just keep doing what they're doing and think they're doing an amazing job. And this is, a left-wing government. It's not like, we're with a conservative government. So we have to continuously think about equity. And even though there's universal benefit with Healing Matters. There's no doubt about it. It's a program that universally does benefit children and young people. It is not reaching and benefiting all children and young people, and that's what we need to change. So we know in Australia, and it would be very similar in Canada and in other places of the world, that child poverty is still a really major issue in high-income countries. We know it's an issue in low middle-income countries, but there is no excuse for high-income countries to have almost 20% of children living in poverty. That's Australia. Okay, so we need to be focused on equity. Equity does matter, and especially for the best start to life, it is very, very important that we ensure equitable access, equitable outcomes, as opposed to the one-size-fits-all approach. So another example of work that I do as a developmental psychologist is obviously, to have the best start in life, we have to make sure that pregnancy, conception and pregnancy work well for mum and for baby, and that health outcomes are positive throughout pregnancy and then the postpartum for mother and child, so maternal and child health. This is a centre of research excellence in health and preconception and pregnancy. I lead that. It's a large national centre. There are 10 investigators and over 350 researchers across Australia and the globe. About 250 of those are early and mid-career researchers. So it's building capacity in early and mid-career researchers, which is all fantastic. This Centre of Research Excellence in Health and Preconception and Pregnancy was awarded in 2019. It took us several goes. They're very difficult to get, very, very competitive. They only award 5 in the whole of the country every year in the area of public health. So fantastic that we were awarded this grant. Fantastic I was leading it. It was focused on maternal obesity prevention. And you can see from my work with Healing Matters, that's a big aspect of my interest. But again, as soon as I got the money, as soon as we got the money and realised, wow, we've got this centre for 5 years, let's do a great job, started talking to the real world and moved beyond that researcher-focused, clinician-focused, because many of the investigators are also obstetricians, midwives, clinician-focused, and really thinking about, will we make a difference across the 5 years? And actually, we weren't going to make a difference, because our approach to maternal obesity prevention, once again, was very Western, was very, universal in approach, but also very much, you've got to fit into this box. If you fit into this box, you'll probably benefit from our interventions and our solutions. And actually, we know that that doesn't get us very far. So we started applying more of an equity lens. I was very keen to start thinking about, okay, if we are wanting to prevent maternal obesity prevention, and over 65% of women in Australia are living in larger bodies, how do they feel about that? How do they feel about Helen Skouteris leading a Centre of Research Excellence to prevent maternal obesity? You are too large. I need to do something about it. Well, actually, when you start talking to women who are living in larger bodies, that's very stigmatising. It's actually quite discriminatory too in terms of how they're treated in the antenatal medical system. And so once you start talking, you realise that, actually, our duty of care is to prevent white stigma, to prevent discrimination, and to support inclusive, caring, compassionate care for all women, irrespective of size. So we have formed the Body Positive Birth Alliance. The other really major issue for us in Australia, and it might be an issue here in Canada as well, First Nations women, if you tick a box and say you are Indigenous, you're Aboriginal, you are then required to have what is considered high-risk care, even if you don't need it, right? And so, again, there's a level of discrimination, a level of racism that continues to pervade the colonial systems and the Western systems of our antenatal services. And the Australian Anti-Racism and Perinatal Practice Alliance was formed so that we can address those very, very serious issues for mothers and babies. And as an example, that alliance and advocacy and the work that we do in support, we're not Aboriginal, we support and are in service, and we can do that to support the advocacy. That's led to the very first, in 2024, the very first Aboriginal-led early parenting centre. So we have 3 established early parenting centres that have been, one's been in existence for over, I think it's 100 years now, actually. So they're really well established, non-Aboriginal led. The Victorian government funded another 11 early parenting centres to be created, none of them Aboriginal led. And so through this alliance, through advocacy, through population reports, we were able to convince and enable the government to support this now. So that's a really good outcome. The other one on that list you'll see there is Growing Queer Families Alliance. And again, you know, the Centre of Research Excellence, the way it was designed, the work that we were going to do was, again, very, very, you know, you got to fit into this box. And we know that that's not the world out there for every single person who is birthing or every single person who is experiencing a pregnancy. So the Growing Queer Families Alliance has grown in strength from the time that I supported its inception in 2020. Now we have governments reaching out to me to say, oh, can we please talk to your lived experience experts in the Growing Queer Family Alliance? Because finally the government is embedding in policies the fact that they need to be inclusive of genders and to understand the experiences of people much more broadly. So how do we genuinely embed equity in implementation science? You can see there my journey and you can see all of the learnings, but how to do this well is something that I'm now embarking on, because we can do it and we can try to do it, but we need to do it really, really well. So we need methodologies and roadmaps and frameworks that really support us to do that. Unfortunately, implementation science as a science has been around for decades now, and there's over, I think there's about 150 framework theories and models that you can use to help you push your evidence from you know, what we know matters and works to what we know translates. So implementation science was developed to bridge that gap between research and practice. You know, we know, as I pointed out at the outset, that there's all of us working in the epidemiological and randomised control trial space, and then when we need to push our evidence across into the real world, we all fall into what we call a valley of death. All right, it's really hard to get out of that. And that's not because we're not good researchers or we're not good clinicians. We just don't know how to do it. That's what implementation science is trying to help us with. But equity, how to use implementation science to advance equity is largely unknown. Researchers and clinicians with implementation science are starting to talk about equity, but actually really understanding how to do it well is a gap in our knowledge. So I was really fortunate to have been awarded a Maureen Brunt Professorial Fellowship by Monash University. And they were only awarded for the first time this year. And that's to tackle this global issue of equity and implementation. Maureen Brunt was the first female professor at Monash University, and the first first professor, women chair of economics in the whole of Australia. And that was 1992. So you can see that from a gender equity perspective, right, we're all very familiar with the fact that with a gender equity perspective, we need a lot of catching up. That's not surprising. But equity overall is an area that we need to do a lot of work in. Maureen Brunt herself came from, low socioeconomic background, and obviously lifted herself out of that by being tertiary educated, becoming a professor and a very successful one, and her family has left philanthropic funding for these fellowships and for scholarships, which is amazing. Excuse me. This is the Brunt Fellowship team. There's quite a few of us there. And so, I can stand up in front of you and take all the credit, but it would never, ever, ever be done without all of these fabulous people who are doing such great work. And in actual fact, I'm learning from them. So it really takes a village, doesn't it, whenever you're doing really large programs of research. Excuse me. So equity, we know, is the absence of unfair, avoidable or remedial differences among groups of people, whether those groups are defined socially, economically, demographically or geographically, or by other dimensions of inequality, such as sex, gender, ethnicity, disability or sexual orientation. And this is, you might have seen this figure. It's a really classic figure that describes equality and equity. And excuse me, I'm just going to have an asthma cough, I think. Is there any water anywhere? Sorry, I'm so sorry. Is there like a water fountain anywhere? My apologies. I just have a bad asthma cough. No, that's okay. I'll keep going. Excuse me. I need to just step out, I will.
Yeah, do you mind? Okay.
Thank you. So sorry about that. I should have brought up some water with me. My apologies. So equality, you can see there, everyone can go to the baseball game, but the ways in which we experience the baseball game are not necessarily the same. And that was the first version of Healing Matters. Okay, so Healing Matters was equal. Everybody had Healing Matters. It's not like they didn't in their homes. Everybody had Healing Matters. But the way in which they experienced Healing Matters, some were like the person, in the blue T-shirt who really benefited, from Healing Matters. And then you've got the person, the smaller person with the purple top, who clearly is really struggling with benefiting. Equity means we provide a little bit more to those who need it so that actually it's fair across the board. And the way in which they are experiencing the baseball game or the way in which they're experiencing Healing Matters or whatever other program you're delivering is fair, right? And that's what we have to achieve for. The fair distribution as opposed to the unfair. This is another example of, I guess, fairness and how our the way that we operate and the way that we do our research might actually be exacerbating health inequities. So this is health economics, and what we tend to do in our randomised controlled trials and with our research is we want to just find out if a program is cost effective, right? If it's saving money. But we don't ever assess the fact that it could be cost effective, but it might be harming equity. Oh, thank you so much. That's fantastic. Thank you. Really appreciate that. And so when you have a win, but then you have a loss, that's not a good thing, okay? And this is what's happening at the moment in our society. We are just focused on cost effectiveness. We stand in front of politicians and we say, oh, you must do this because it's going to be cost effective and you're going to save money. But actually, we don't say, oh, that's fantastic, 2 people. Oh, that's lovely. Thank you so much. I really appreciate that. That's fantastic. But we don't actually say to those politicians or to the funders, but actually, if you implement this, we might be exacerbating health inequities. No, we keep that quiet because that it doesn't suit our narrative, right? Well, it's got to suit our narrative. We have to be focused on equity as well, because if we're implementing something, like when I was implementing Healing Matters, and it actually was creating more inequities because the young people who I was leaving behind felt even more traumatised and even more discriminated against and even more like, well, what's the point? Nobody sees us, nobody cares. That's not good enough, right? We can't do that. So we have to be thinking about a win-win, cost effectiveness and programs that improve equity. That's almost impossible, right? I mean, you know, let's face it, it can happen, but we know it's not easy. That's what we need to strive for, win-win. But in actual fact, what we could do and flip the narrative and support these discussions with government and with funders, even if it's a loss to begin with, even if our intervention is not cost effective, it's cost ineffective. If it's improving equity, then we need to push that. And we need to say to governments, eventually over time, if we are improving equity, and especially amongst First Nations communities, if we are improving equity, let's not talk about cost effectiveness for now. Let's do what we have to do, because eventually, if we improve inequities and we bridge that gap that we all talk about, that's going to save government's funding. The problem that we have is the short cycle of government, right? And so they don't care, really. At the end of the day, they're like, well, what can happen in my 4-year term? Because I might not be here after 4 years or whatever their term is. But the loss win is really, really important. So our vision with my professorial fellowship is to develop Australia's first programmatic multi-sectoral study of equity-centred implementation science across health, social care and education. And there are different aspects to the program of research with lived experience experts driving this program of work. So they're in a completely different colour to the programs of research, because actually we're not doing anything without them, and they are our world. You know, they're basically the ones that we look to drive this program of research. Equity is at the heart. And so this is just another depiction of the work that we're doing with the lived experience experts network, you know, literally informing the programs of research. We are focused on a program planning methodology called intervention mapping. You might not have heard of it, but it's it's one of the sort of the most highly used approaches to plan and design interventions or programs, resources, whatever you need to design. If we don't have an intervention, we don't have a program, then we don't have implementation science. So we need to have a program and intervention. And how do we design that? How do we plan for that? Right? Intervention mapping and implementation mapping is a very methodical approach to that. But unfortunately, even though equity is implicit in that methodology, that approach, it's not explicit. So we are looking into how can we embed equity explicitly in intervention planning, design, and implementation. We then need to understand how we can implement those interventions that we've designed with strategies. They're called implementation strategies. So how is equity also embedded in implementation strategies? Again, we don't know that. So we're looking into that as a program of research. And then we're also developing conceptual understanding that helps us to move the field beyond, a single discipline, very much focused on health, very, very hierarchical, because, of course, disadvantage also exists in social care and education, and those sectors and disciplines are just as important. Okay, the other thing we have here is voices of children. Very, very important that if we're focused on the best start to life, that we actually ask children. And so we are incorporating the voices of children. This is just a lovely example of some of the work we've already done with them about what does fair mean to you. And if we don't hear their voices, then we will never again, as I've been saying, be able to really make a meaningful contribution to their life. So I'm not going to go through these in a lot of detail. If anyone would like some more information, I'm really happy to chat at any time. You can email me at any time and we can talk more about it. But to work with intervention mapping and program development, we wanted to first understand holistically about equity in program development frameworks, because intervention mapping is just one approach. There are many. And we really wanted to understand, what are the equity-focused principles that might be part of these development frameworks, even if they're not explicit. What are they? And to what extent and how are equity-focused principles embedded in program development frameworks, and make some recommendations for embedding equity as a process in these development frameworks. So this is just, as I said, I'm not going to go through the detail, but for the first phase, we have identified 85 papers. And if we go back, that's to literally just identify equity-focused principles. What are the equity-focused principles? And as an example there, you have equity and the things that we need to prioritise, support and ensure exist. And then we've got community and culture. We've obviously tried to categorise the principles, but this is a work in progress and it might change. Identities and determinants. And then also for intentionality for equity, with an equity mindset, what would that systems approach look like? So equity in identifying the target population, in program development processes, in program element design, and in equity in outcomes. Very, very important that it's across the board. So that's the first part. Phase 2 is 71 program development frameworks have been identified, and we will use O'Cathane's, Alicia's, Alicia is from the UK, her taxonomy to understand how equity is defined and operationalised in these frameworks, if at all. And we do know, we have obviously interrogated the literature. There is implicit understanding of equity. The explicit aspect is what's missing. Very, very rare that it's explicit. You know, you must do this. This is what equity looks like. This is what you must do. And I feel like that's why we don't have the roadmaps. We don't understand how we need to do this. So equity in program development, we've run a whole series of workshops to understand how we can understand equity best through the intervention mapping framework. How can we, as program planners, if we're planning for a program or an intervention, how can we ensure that we are thinking equity right from the outset, not as an afterthought, which is what I did with Healing Matters, with my Centre of Research Excellence. You've seen that, you've seen those examples now of how I'm backtracking after many, many years and lots of funds have been spent and thinking, oh my goodness, I've left people behind. How do we actually reverse that and think about everybody that needs to be thought about? And we can't reach everybody, but we still need to have an equity focus, not a lens. If it's a lens, what you're doing is what I did with Healing Matters and with my Centre of Research Excellence. You do all the work and then you think, oh gosh, I didn't pop this lens on. I better pop this lens on now, you know, put my glasses on and let me see what I've done wrong. We need an equity focus and explicit focus right from the outset. So the work that we've done so far, we've done workshops with Professor Maria Fernandez, who is the developer of intervention mapping. We've done that in Australia. We've done work with colleagues from Nigeria, with colleagues from Monash, Malaysia, Jacob Baru. We've done some workshop in Leuven with European colleagues, and we've also done a workshop with policymakers from the Australian Prevention Partnership Centre. We're doing a 5-day workshop in Malaysia again, but in Kuala Lumpur this time in December. And we are also going to be working with First Nations communities and colleagues and other multicultural communities, so that we have a really broad depth of understanding. So this is just an example of what is needed to embed equity in program planning. It's not a Bible, it's not the truth necessarily, it's just what our current public contributors have told us might be important in terms of intentional planning, building equitable teams, generating ideas. This is what they told us is needed. Leadership and organisational support forums, shift in policy, you know. So this is just an example. We've done these, like there's this slide for all the workshops that we've done, and we're just trying to bring together the massive information. We also ask them for guiding questions for program planners, because if we have questions that we ask ourselves, if we know there's this list of questions, it will keep us accountable, because it will, you know, have we considered how to reach and engage? How do we remain authentic and listen to communication and voices that are different to ours? You know, if we just have these series of questions and we know that we need to focus on those, it will help us to, as I said, focus on equity right from the outset with no excuses. And so this, we're trying, you know, again, this is a work in progress. We're trying to create an intervention mapping equity wheel where, you know, around the outset of the wheel are the intervention mapping steps and tasks that you have to go through. And then in the middle bit, there are the intervention mapping core processes. So they exist, right? That's what you do when you use intervention mapping. You have your steps and tasks and you have core processes. But what we're trying to bring to the approach is equity at the heart. Okay, and so what you need to do for all of those steps and for all of those core processes, understand how to empower the voice of lived experience, how to be intentional and explicit in planning for equity, how to use reflective processes, and how to use equity theories, methods, and frameworks. They don't exist, we might have to develop them, but how do you think theoretically? There are other theories, and sorry, my apologies. They don't necessarily exist for intervention mapping in the book at the moment because it's very heavily reliant on behaviour change theories. But there are other equity theories and models and frameworks that we can apply to our intervention mapping. So, and this is just the last one. This is the taxonomy of equity methods and strategies, because without strategies, we can't implement something. And we're doing that across healthcare, social care, and education. So I'll leave it there. I'll leave this slide up so you can keep reading it. But I'll leave it there because I promised that I would finish with 10 minutes or so of time for questions, and we don't have to have questions, but it would be lovely if you wanted to ask something that you had time to do so. Thank you very much. Thanks for listening.
I have a question. First off, thank you so much for this awesome presentation. I'm wondering, do you think like the theories for equity that like are out there right now are like, I guess, like sufficient, and like if not, which, or is there like an area that like you think that folks should like focus on and like develop more to be like more inclusive of like people that may like fall like beyond like, I don't know, like marginalized? Or
Yeah. It's a really good question, and there are definitely theories that we can tap into, especially across social determinants and racism and colonisation. There are theories that we can turn to. I think what we need to do though is partner with lived experience, partner with communities who are experiencing adversity for the reasons that they are, and then also develop up, I guess, very tailored and meaningful theories that make sense to them, especially from a First Nations perspective, because our current implementation science theories, models, and frameworks have pretty much been developed by people like me, very white, very privileged, often men, not always men, but often men, from Western Eurocentric perspectives and countries like the UK, the US, Canada, and Australia. And that's not the world, right? So the other thing that we do is we then think, and we can definitely support, and we definitely, so this is not a criticism of our knowledge to date and all the work that we've done. It's been very, very important. But then we take our Western approaches and our Western ways of thinking into the global South, and work with low middle income countries and say, okay, we're here to support you. In actual fact, when you talk to colleagues from these countries, those techniques haven't necessarily worked. And as a classic example of that, we're trying to eradicate cervical cancer. The WHO, is on a mission to, eradicate it. It should not be in existence. But the reality is, in countries where there is high prevalence of HIV, the funding might go to just HIV, and so then, or if you have got funding for cervical cancer, screening. It's very universal, which is what a very Western approach. We do that in Australia. We have everyone is enabled to have bowel cancer screening, as an example, or breast cancer screening. My parents don't know how to manoeuvre a kit that comes into their letterbox and, you know, says, even if it's in Greek, you know, so they've got me and I can support them. But there are families that don't have someone like me that actually might just say, oh, well, we don't really understand that and we don't really want the government knowing the results of that test and where are those results going. And we've got to remember that our migrants, refugees have come from mistrust of government. And so why do we then just think our way, the Western way, is the way that they should be supported? So thankfully in Australia, because of COVID-19, our federal government now is really focused on multicultural health, and they have instigated some very large cancer screening and COVID-19 vaccination support systems. My team and I are helping the federal government to actually just give the power to the communities. Just give them the opportunity to work with their communities. And guess what? It's working. It's not rocket science, you know, because they know their communities best. It might be their religious leader that's actually telling them you need to get screened for cancer. It might be, you know, we laughed with Malaysian colleagues because it might be the mother-in-law. Doesn't really matter, does it? Doesn't matter, does it? It's not about what we think is important and who the communicator should be. It actually should be what the community is saying will get the message out, will increase vaccinations or will increase screening, because that's what we want. Universal approaches don't work, even though they're free. And that's a real eye-opening you know, result for low middle income countries that have spent a lot of money in providing free access to screening and then realising that women are still not coming. Okay? So you have to do things that are tailored and appropriate and not necessarily the way that's been done for women like me. Because of course I do my bowel screening and of course I do my breast cancer screening. A no-brainer, but we have to always understand why that's not working and not be judgmental, because I have heard people say, oh, well, they're just totally, you know, they're just ungrateful. You know, it's free, comes to their doorstep and they still can't do it. That's a really awful way of thinking as well, isn't it? Because again, it's tailored to, you know, how I operate in life and works really well for me, my daughter, you know, the way that we operate, but not necessarily for other communities. I'm not sure if I answered your question, but yeah, it's really bringing in, from a theoretical perspective and a mechanistic perspective, the voice of community, because they will help, they will drive science. They will help us understand, you know, how we make this work. We just have to partner with them genuinely, not a tick box, which is what's been happening in the past. Yeah.
Questions online?
I wanted to ask about your amazing slide that showed the cost effectiveness and the equity in the four quadrants. And it's just because I think you made a point that I have not heard made before, and that is, you know, the win-lose, where, or the lose-win, where even if it improves equity, then it shouldn't matter if it's cost effective.
That's it.
Have you had any experience or success with government or other leadership bodies kind of pushing that forward? Because I think it's a really important message, but I think it can be a bit of a barrier to actually get that across into action.
Yeah, it is a huge barrier, and we're trying to come together with health economists, implementation science experts and equity experts so that we can drive a bit of advocacy. I was fortunate to speak to a minister in government who ran a roundtable for multicultural health, and she liked it. Like, she did not say to me, that will never, ever happen, Helen, if it can't be cost effective. She actually got it. Like she said, oh, yeah, I see what you mean. And I think some of the things that they're doing at the moment with multicultural communities for cervical cancer screening and other cancer screenings and COVID-19 might not necessarily be cost effective because they're spending a lot of money, like a lot of money. But I think because they're seeing results and they're seeing, oh, okay, we might not see it immediately, but we're seeing that actually the benefits of this will be longer lasting, because if they are vaccinating for COVID-19 and they are screening, we might not see the benefits right now, like today, for the money that we've invested, but hopefully 2 or 3 years down the track, we might see better health outcomes. That might be an example. They didn't do it at the time thinking of this, but, if, because this is sort of a new way of thinking, and we're trying to get our heads around it in terms of research, but also advocacy. But if I think about Healing Matters as well, I know Healing Matters has been expenditure for the government, like they have spent money, right? We haven't done, they've never asked for a cost effectiveness analysis, but I know that if we did it, it would come out as being cost ineffective. Right. Because you can't, for these young people who are living with most vulnerability and disadvantage, you cannot, like the short term means nothing, right? Because they're still coming in and out of detention, they're still prostituting, they're still dropping out of school. What will happen, though, is if the culture of out-of-home care, though, over time is embedded and ingrained. So when we spoke to one young person about Healing Matters and asked him, do you like Healing Matters? And he said, yeah, I love it, because I walk the 5 kilometres to my dealer now. I don't catch the bus. Now, I'm not going to stop the drug taking at their end, but for him to say that, it means that he is starting to think that walking is important for his health. At some point, you hope that he will put 2 and 2 together as well and say, well, then why am I walking 5 kilometres but then taking drugs? But that takes time, doesn't it? But if the system around him is constantly Healing Matters, like it's constantly, because it's much more than food now and physical activity. It's not. It's about, sleep routines and mental health and gender identity and, all the things that we talked about, in terms of supporting them holistically. If they really identify with that and feel the care and compassion and feel like, okay, there's this wraparound, maybe I can do this, maybe I can, with supports, I can lift myself out of the trauma and the disadvantage. The trauma will always be there, but be able to live with it. That's what we're hoping for healing. That's what the organisations are hoping for. That's why everyone's embedding it. They can really see that the shift is making a difference, even if you can't measure it immediately for cost effectiveness. They're seeing that it's improving equity. And the young people are too. So, we have to get better at these analyses, though, in terms of measuring equity. That's the other thing. We don't have measurements. Right. So this is the problem. You would probably know that from your First Nations communities. We are so far behind. Most of our data sets are, of people like me, tertiary educated, because we're the ones that fill out questionnaires and give permission for our data to be used. So we also have to think much more creatively about how we collect data across multicultural communities, First Nation communities, LGBTIQ. We're missing all of that. We don't, in Australia, we weren't even asking about gender diversity. We are now in the census, but it was almost like it was just a completely hidden, it's not hidden. These people exist and it's awful, isn't it? So yeah, I've run over time, I'm sorry.
No. Any last minute questions on that? I just Carola says thank you for a very insightful presentation.
Oh, that's lovely. Thank you very much.
Thank you so much.
Thank you, everyone.